Great. Well, welcome everybody. I'm Brian McCloskey, and I'm a co-founder of the Cancer Patient Lab. I'm glad that you all could make today's session. We're very honored today to have Saul Priceman join us. But before I get into an introduction to him, I wanted to remind folks of a few things regarding this session. First off, this is not medical advice, so please make sure to consult your physician before you take any action on any information that you would learn today. The other thing is that this is going to be recorded, transcribed, and it will be made publicly available on YouTube and on our website. So if you don't want to have your name divulged, just go into your Zoom settings and modify them. You can turn your camera black, turn it off, or get rid of your name. Lots of different options on that. And then finally, we are a nonprofit, and so all of our expenses are paid for through the great support of our community. And so if you'd like to join, or if you'd like to donate, please go to our website and hit the donate button, and you can make a donation there. So with that, I am super excited to have Saul Priceman, Dr. Saul Priceman, join us today. I've known Saul now for probably 4 years or so when we met in DC at a convention. And Saul's been very helpful in my journey as a prostate cancer patient. And I'm happy that he's here. And he was for many years he was driving the CAR T development at the City of Hope, and just in September, Saul became the founding director of the Keck School of Medicine and Norris Cancer Center's Cancer Cellular Immunotherapy Research at USC. He is an expert in CAR T. And has driven many programs. And so today he's going to talk about what CAR T is, particularly as it relates to solid tumors, which is going to be most appropriate for our community, and what the latest and greatest is with CAR T. And so I'm excited to have him join us, and looking forward to an interactive conversation. He'll give about 15-20 minutes of overview, and then we're going to open it up for Q&A. So with that, Saul, I'm going to turn it over to you.
Thank you, Brian, for the introduction. So, good morning. I'm happy to be here. I think it's the first time I've done this.
It is, yes. We've been trying to get you for a while, but this is your first.
Yeah.
You're a busy guy.
So, just a little background to me. I've I'm 45 years old, and I've lived in Los Angeles for 42 of those years. I went to UC Santa Barbara for undergrad. I worked at a company called Amgen, which you may have heard of, in Thousand Oaks for a couple of years, and decided to go get my PhD at UCLA. And after that, I went straight to City of Hope, and have spent the last 14 years there as a postdoctoral fellow, and moving all the way through junior faculty to an associate professor position. And then, as Brian said, in September, I moved to USC to lead their Cancer Cell Therapy Center. And it's a great opportunity because, City of Hope has been well established in this area with 40 plus years of bone marrow transplants, which is the most, someone's going to get mad at me, but the archaic version of cellular immunotherapy. And over the last 20 or so years have been doing what we now term as synthetic engineering and adoptive cellular therapy, and I'll describe that. And then my move to USC is really to build that out here. And the idea with that is that every institution under the sun, but certainly in the United States, should be doing cellular immunotherapy, whether it's CAR T cell therapy or other immunotherapy approaches, because I do believe that rewiring the immune system probably has a hand in every single disease, every single human disease, and certainly in cancer, if we can redirect the immune system to identify that cancer, that is the most likely to provide durable therapeutic responses as opposed to what we're all used to, which is types of chemotherapies or other druggable entities that you have to take over and over again. And there's no evolution of that therapy. Once you have resistance to that therapy, you're in need of something else rather than what the immune system could provide, which is something that evolves with the cancer and could be there for much longer or indefinitely. Sort of we could go into an immunology 101 and we can describe how, when you're vaccinated at a very young age or infected with something at a very young age, your immune system recognizes it and can recognize it for the rest of your life. And if we can do that with cancer, that would be the best approach. So I have more than 20 minutes of slides, but I think, what do you guys see?
So we see your whole desktop. There we go.
Is it in full presentation mode?
It looks like it's in full presentation mode. Yeah.
Okay, great.
Can everybody see that? Anybody can't? Okay, I think we're good to go.
So I didn't know the crowd. I didn't know how many Gilead employees or scientists we've on here.
We've got a pretty scientific crowd even with our patients. So don't hold back.
I love that. Well, I have 30 some odd slides, so I'm going to run through some of them, and I may skip some of them, but they'll be there, and I can send the slide deck over to Cancer Patient Lab, and you can all read through it. And I'm obviously always around if there are questions, and we can provide my email address. So I thought I'd start here, like what makes up a cancer. When I was growing up and learned about cancer, I thought it was all cancer cells sitting in a mass. But the reality is it's a mosaic of all different types of cells. So if you just looked at a gross tumor, which is gross by definition, but also growth by histology, you can see that there's a lot going on there. And if you just take that little bit and you look at it at a high magnification at the different cells, you can appreciate that there are tons of different types of cells there, even by gross histology, which doesn't tell you what each of those cells are. I'm going to show an animation that shows you what cells there could be, which is in dark brown is a tumor cell, but you also have immune cells, mostly fibroblasts, which make up the tissue integrity. You have vasculature and other cell types. I'll go into a bit more detail about the immune system, but not too much. I mean, we could spend hours on this, but there are cytotoxic T cells, which we really focus on, which are your killer cells. They actually identify virally infected cells or cancer cells and literally touch them, poke holes in them, disrupt their cellular integrity, and they ultimately die. Those are the things that fight off infections. And in cancer, and I'm blowing through this, sorry, but in cancer, we really term cancers just in a spectrum, but really two ends of the spectrum, which is immunologically cold, and I'll define that, or immunologically warm. Some tumors have an immune response. Their makeup of the tumor could be up to 50% of the mass is infiltrated by immune cells. What are they doing there? They're actually seeing the cancer and they want to fight the cancer, but they're being overcome by some mechanism. Versus immunologically cold tumors where there's literally nothing happening. The immune system has not recognized it or did and has given up, or the tumor evaded that recognition, and those immune cells have left the country. They're not seeing anything. And the most common examples of that, unfortunately, are prostate cancer and pancreatic cancer. There are a number of those cancers that are deemed immunologically cold. And there are some cancers that are immunologically warm. They have an immune response happening. They have to be unleashed in some way. But melanoma, lymphoma, kidney cancer, and a number of others, if you put an immune checkpoint blocking antibody, which I'm sure most of you have heard of, that's the classical immunotherapy, you can release a brake that's being put on the immune system, and the immune system can recognize the cancer. In some cancers, and I mentioned prostate cancer, that's termed MCRPC here because that's metastatic castrate-resistant prostate cancer. The responses, and I'll only show a couple of slides of survival. I don't like these slides, but You have to show them to show what the response rate is. If you compared it to control, immune checkpoint blocking antibodies in metastatic castrate-resistant prostate cancer are relatively underwhelming. There's little response. There have been responses demonstrated in some patients who have what's called microsatellite instability, which creates more DNA mutations in the cancer cell. They're more likely to present things to the immune system. They're more likely to respond to an immune checkpoint blocking antibody. That's in contrast to melanoma, which I mentioned before, where if you look at the survival rate, and unfortunately, this survival curve doesn't show what used to happen, which would drop off completely before, let's say, 24 months. Now you're getting a durable curative response in about 25% of patients. If you combine some immune checkpoint blocking antibodies, you can provide curative responses to about 50% of patients with advanced melanoma, which is striking and suggests that in immunologically warm tumors, you can redirect the immune system to recognize and fight off the cancer in a durable way. Going back to prostate cancer, there are a number of trials where they're combining immune checkpoint blocking antibodies with other therapies, and I won't go through the list, but I will send this to you, and these are the NCT numbers, so they're the clinical trial numbers. You can find them depending on where you live, what you're eligible for. And I'm a scientist, so I won't go through the inclusion-exclusion criterias for these trials, but you should look at them. They are combinatorial therapies based on mechanistic hypotheses that suggest that these combinations with checkpoints will improve the responses in otherwise immunologically cold tumors like prostate cancer. Many, many years ago, the first FDA-approved cellular immunotherapy was actually for prostate cancer. It was called Sipuleucel T. Many of you may know this, and I won't go through the details of this either, but it's basically one of the immune cells called a dendritic cell, which is the guy that goes to a tissue, finds some bad stuff, gobbles it up, presents that to the T cell. The T cell then recognizes exactly what that gobbled up stuff is, and then goes out and finds those things and kills them. Pretty smart scientists decided we're going to take those dendritic cells out. We're going to give them what they need to recognize to present to the T cell, and we'll infuse them back into patients. And the responses have been okay. They're not really great, but what they did suggest was that even in immunologically cold tumors, you could maybe develop a cellular immunotherapy that changes the landscape of treatment for patients. And then we get to the more active and more specific types of immunotherapy. So I'll cover those today, which is CAR T cells, which stands for chimeric antigen receptor T cell, and bispecific T cell engagers. I'll go through a bit of it. A CAR T cell is on the bottom right here illustration, if you see my arrow. Basically what we do is we take T cells out of the body of patient A. We engineer those T cells with a CAR, which is a synthetic receptor that's displayed on the surface of that cell, and that then allows redirection of that T cell to identify a cancer marker. And then we put them back into the body, and they go seek out that cancer marker. When they identify that cancer marker on the surface of a tumor cell, they engage and kill that tumor cell. That, and I'll show you some clinical data and some FDA approvals that have already happened with CAR T cells. And bispecific T cell engagers are a little more of a druggable version of that. It's not cellular therapy where you infuse a cell, but you're infusing a drug, and what that drug does is physically links the T cell with the tumor cell using similar mechanisms, but it's an antibody with two specificities. It touches the T cell, it touches the tumor cell, puts them in close proximity, and the T cell gets excited and kills that cell. Those things are being actively worked on. In prostate cancer, and so backing up a little bit, I work on prostate cancer, but it's not my sole focus. Most immunotherapy people don't work on one cancer because they think that this type of immunotherapy can work for multiple cancers, but I'm highlighting prostate because sort of where we started. There are now actively 3 and more bispecific T-cell engager therapies that are being pursued in prostate cancer. One targeting our favorite, PSMA, which is prostate-specific membrane antigen, which has been all the rage in prostate cancer recently because of diagnostic utility as well as therapies like radioligand therapies, which is systemic radiation that's been approved now targeting PSMA-positive prostate cancers. STEAP1 is a new kid on the block, very exciting, and I'll show some PSA responses with STEAP1 bispecifics. And then next generation PSMA bispecifics also being tested. I'm not going to go through adverse effects very much, but none of these immunotherapies are without immunological responses and some adverse toxicities. And you can see that here. Most commonly actually is cytokine release syndrome, which is a response to inducing an immune response in a patient where they have more cytokines being produced, which are mediators of the immune system, mediators of the immune response. And they can be somewhat dramatic. They're typically resolved, but in most severe cases, that can actually cause mortality. But the PSA responses, which is a measure of, it's a prostate serum antigen, it's a biomarker of prostate cancer progression. You can see that anything below the 0 line and closer to the -100 means a dramatic response, almost a complete response, and higher means that patient progressed. Most patients, 2/3 of them, had a response. Some of them had a pretty dramatic response with PSMA. Whether the responses are durable or not, we're still understanding that. If you look at that and compare that to STEAP1 bispecific T-cell engagers, look at how many patients got close to 100% reduction in PSA, which means they had a pretty dramatic response. Overall, about 30% of patients had a PSA 90, which means it dropped 90% or more. Most patients had a PSA 50, which is pretty striking. That means that if done right, and maybe in years to come, we will absolutely do it right, we can get rid of the toxicities that are associated with these therapies, but we can have dramatic therapeutic responses even in prostate cancer, which is immunologically cold. And it gets to more adoptive cell therapy options, and I'm just going to go through the 3 general buckets for cellular immunotherapies. One is CAR T cells, and I'll go through much of that in a minute. Another one is an engineering approach as well, but we're not putting a CAR on it. We're actually putting a receptor called a TCR that is the native receptor that the T cell uses to recognize a virally infected cell or a cancer cell. And there are reasons why people are doing this as opposed to CAR T cells, and I won't go through that in detail. And then there's maybe a more crude method, but in many ways has been really effective, is just taking a tumor out of a patient, resecting it out of the patient, cutting it up, getting the T cells out of that tumor and growing those in a dish, and then infusing those back in, as opposed to synthetically engineering those cells. You're just taking the guys that are already in the tumor and growing them up to billions and putting them back into the same patient. And as you can imagine, unfortunately, this works just from a technical standpoint, works for people who are immunologically warm, for tumors who are immunologically warm, because you need those T cells to already be sitting in the tumor. So a bit about, please, I think, interrupt, right? We're not waiting till then to ask questions.
Yeah, if somebody does have a question, we want to make it interactive, we can do that as well.
Yeah.
Just raise your hand, use your the raise hand feature, and I'll call on you.
Okay. I think I'm going to move pretty quickly from now because I did want to get to the question answer portion. But I think this is a very complicated field, and I wanted to make sure you left with more insight maybe than previously, and will allow you to look at papers and read them more constructively and talk to your clinical teams about these types of therapies. CAR T cells are pretty cool. Again, we take T cells out of the body from the blood, and we engineer them using viruses that don't give you a viral infection, but do what viruses do best, which is insert genes into the genome of that cell. And in this case, we're inserting a chimeric antigen receptor that gets made into a protein. The protein shuttles to the surface, and you have a CAR sitting on the surface of the T cell that recognizes a cancer. This has gone through multiple evolutions because it is synthetic design. You can actually make any DNA gene sequence that you want really in a lab and put it into a T cell. So we've been going to town with that to try and understand what the best constructs and designs would be to engineer a T cell. Because of that, we've now seen 7 FDA approvals, all in the context of hematologic malignancies like lymphoma, leukemia, and multiple myeloma. And they work exceptionally well in certain diseases. So just as an example, in acute lymphocytic leukemia, where patients are multiply refractory to other therapies, including bone marrow transplants, and have exhausted all other options, if you infuse them with a CAR T cell targeting CD19, which is the molecule we go after in B cell malignancies like ALL, almost 90% of the time you go into complete remission within 28 days. And in about 40% of the time, you have a complete response that's durable for a long, long period of time. That is striking because otherwise these patients have no other therapeutic options. And with that, we're really trying to get into how do we do this for solid tumors, and I'll go through that. But what we've learned, though, is that some antigens, some targets that we go after in cancer, and specifically for lymphoma leukemia, are really good. And for reasons we understand, and some of them we are still trying to appreciate, and I won't go into too much detail. But now you can do the following, which is, well, what's better, a bispecific T cell engager, a TCE, a CAR T cell, or ADC, which is antibody drug conjugate, which is, I didn't go through that because it's not a traditional immunotherapy, but what that is an antibody, a targeting molecule, tethered to a chemotherapy that you infuse. That targeting molecule does what it does on CAR T cells and bispecific T cell engagers. It sees the cancer cell, and now that chemotherapy goes into the cancer cell. If you compare those in one disease, this is multiple myeloma, but you compare all 3 of these therapies, CAR T cells were the most significant in terms of response and durability of response compared to bispecific T cell engagers and antibody drug conjugates. This isn't to say that in prostate cancer we'll see the same, but at least it tells us that we can benchmark CAR T cells as a very viable approach for certain diseases. If you look at solid cancers, we've gone after a number of targets. I showed you PSMA and STEAP1 for prostate cancer, but look at all of these targets that we're going after. Here's PSMA for prostate. STEAP1 is not on here, but there are a ton of targets we've gone after and a ton of diseases, hepatocellular liver cancers, neuroblastoma, sarcomas, prostate, triple negative breast cancer, tons of different types of cancers. And if you compare the responses here, unfortunately, to hematologic malignancies like ALL and lymphoma, we have not appreciated the same level of response. There are a number of reasons to that that we're all evaluating, and I'm going to share a little bit on that. I just wanted to highlight a couple of responses. This was actually at City of Hope. This is how nimble cancer centers can be. We targeted glioblastoma, which is the most deadly form of brain tumor. We took the route that if you infuse T cells that we engineer into the bloodstream, their chances of getting to the brain were very limited versus if we gave the T cells directly into the brain. So this trial actually gave the T cells directly into the brain, into the tumor, in some patients into the tumor cavity that remained after they did a tumor surgery and removed the tumor. And in one patient, which we published many, many years ago now, they had their tumor removed, they infused the T cells, and those T cells never came back. But he had multifocal disease. He had more regions of the brain that had lesions, and he also had a spine metastasis. And we had preclinical lab mouse data that suggested that we could give these T cells not directly into the tumor bed, but rather into the ventricle that houses the cerebrospinal fluid and bathes the central nervous system. And our hypothesis was that these T cells would then distribute all around the brain and the spine, and you could target multiple regions rather than just injecting them directly into one site and asking them to then migrate to another site, those immune cells. And that's exactly what happened. He had a dramatic response and regression of his brain, multifocal brain and spinal metastases, and you can see that quantified here. They were all growing after we gave intratumoral administration, and then when we turned to intraventricular, he had regression. We had to get to the FDA within 30 days and beg them to do this. This was a first in patient ever to receive intraventricular CAR T cells, and we saw this dramatic response. Unfortunately, the trial has had its challenges. We do not see this response in every patient. That's with every immunotherapy for reasons, again, we can appreciate and some we don't. We have responses in some, but not all patients. This is another trial for gastric cancer where you can see this is a measure of the reduction in tumor size. You can see some patients had an absolute eradication of disease. Some patients had partial responses, and the survival looks better than historical, and comparing some selected patients with higher expression of the target. In my lab at City of Hope, we really focused on 4 diseases: prostate, breast to brain metastasis, which is breast cancers that have spread to the brain, and ovarian cancer, and now pancreatic cancer. We've worked with, which is the beauty of this foundation, this series, as well as others that we all as scientists and clinicians partake in, is networks and collaborations, and we're collaborating with a number of labs around prostate cancer specifically. This is a list of the trials for CAR T cells and bispecific T cell engagers for prostate. We actually started a trial several years ago targeting another antigen on prostate cancer called prostate stem cell antigen, not PSMA, but PSCA. And it correlates with disease progression and higher expression with reduced survival in patients. Its expression is high in primary prostate cancer as well as bone metastatic disease. I did want to show this, which is just one set of animal studies, and then I have another set, but I'll avoid that because I'm already running out of time. But these are the types of lab studies that we do to try and get something into a patient. These are the types of foundational studies. We actually developed a PSCA-directed CAR T cell, which took a lot of time to design the construct, engineer T cells, and prove it. We built a mouse model that addressed both the safety issues around this type of therapy, because once we went to trial, we were actually the first to put into a patient a PSCA-directed CAR T cell, which could wreak havoc. And unless we predicted that somewhat in our laboratory, then we were going sort of blinded. We had great therapeutic responses in very easy models. We put this into a mouse model that had a intact immune system, and the expression of PSCA, the target in the prostate cancer, is also expressed in normal bladder cells, so we worried about toxicity. Unfortunately, when we gave the CAR T cells, and this graph is just measuring tumor growth over time, you can see that if you left these animals untreated, the tumors grew out exponentially, and if you treated them with PSCA CAR, they grew out exponentially. We actually had no therapeutic response. And this contrasted data we already had in mice that don't have an immune system, that the CAR T cells worked really well in a dish and in those mice. But in these mice, they didn't work. We had to precondition those animals with what's called lymphodepletion, which is a set of chemotherapies that are just given 3 times over the course in less than a week, that primes the body to accept and receive the CAR T cells. And that therapy alone had some delay in tumors, but all of them grew out. Now, when we combine with our CAR T cells, we had curative responses in our animals in up to 40%. And this started the trial that we undertook now many years ago, where we dose escalated the PSCA CAR T cells. We added or didn't add lymphodepletion. I'm not going to go through the details here. Unfortunately, we had some PSA responses. We had a dramatic PSA response in a patient who had reductions in their bone metastatic disease all around the body. We work with a group who I think presented here, Peter Kuhn, who's at USC, that does circulating tumor cell analysis, which is a liquid biopsy assessment, and we worked with him and showed dramatic reductions in these brown cells, which are classical prostate cancer cells that are circulating through the blood. We had reductions in that. We also had infiltration of T cells into the tumor. This is where we sort of do our downstream analyses to understand the biology. This patient was unique, actually had a stent in his pancreas, and around the stent had pancreatic metastatic disease from prostate. It was prostate cancer around in the pancreas, and had almost complete resolution of that disease. And I won't go through this data, but it highlights a bunch of challenges, the reasons why we see dramatic and durable responses in blood cancers, but we're not appreciating that in solid tumors. And it's really the microenvironment in the tumor, which I showed on my second slide, which is that there's a ton of cells that are barriers to getting immunotherapies to work in solid tumors, and what's called antigen heterogeneity, which is, we go after PSCA in prostate cancer, but the PSCA has to be expressed on 100% of the cancers if we anticipate a 100% response, and they don't. So there's heterogeneity, or a mosaic of cell types that make up the prostate cancer cells, or any other cancer, and it's difficult to wrap a therapy around all of that. I'm going to skip through this, but we have now a trial with radiation and CAR T cells, and I'm gonna end it, but happy to answer questions.
Yeah, thanks, Saul. So for everyone, there are a few questions that have popped up in the chat. Please use the raise hand feature if you'd like to ask Saul a question. I'm going to get us going, though. So when you look at cancer patients, let's just take prostate cancer. How do you identify cancer patients that are going to respond well versus those that aren't going to respond well to CAR T?
Unfortunately, at this point, we don't know. I don't think there is a test now. There is not a test now that will predict whether someone will respond. I think, when we start a trial with a PSCA CAR or a PSMA CAR, we definitely look for that marker on the cancer cell. And that's a critical component. I think in the very near future, because there's a lot of research going into what makes up a responding patient versus a non-responding patient, I think we will know. There are certain hints to it, but we don't use that to guide our therapies as of yet. It's just too new, relatively speaking, and it is highly specific, so I think we're trying to understand that.
And then what about a multi-targeted approach, right? Given the fact that we've got heterogeneity, what are the possibilities of having a PSMA targeted one and a STEAP targeted one, or HER2?
It's happening.
Whatever. Okay.
Yeah, it's happening. I think it's already in trial for certain cancers, mostly blood cancers, because they were a bit ahead of the solid tumor folks, researchers. But we are advancing those in our lab, and there's a lot of utility to that. And we can do that, as I mentioned, a CAR or anything that you engineer in an immune cell. And I only went through T cells, but there are tons of different immune cells people are engineering, and I didn't have time to go through it. I wish I did, and I'm happy to come back and do that, but it's endless. You can engineer the CAR or the TCR or anything with anything you can imagine. You just have to prove that it works in a lab, and you have to convince the FDA to get to trial, and we're all doing that. I think the possibilities are endless, literally.
Awesome. So there's a few questions in the chat. If you want to raise your hand, Rick Davis, I see that you've got a question about the pros and cons of CAR T versus bispecific. So
I had a slide on that. But I was told at a younger age not to go back to past that.
Yeah, you can if you think it's illustrative.
No, I remember it all. I mean, there's a bunch of different considerations. So one is right now, and this is going to change and imminently, right now, a CAR T cell, the way it works is you identify a patient, they go through an apheresis, which is a larger blood draw, and we call that vein, okay? And then they go through a manufacturing process. They have to be released. The sterility of those cells have to be checked, and a bunch of other things under quality control. And then they're infused back into the vein. From vein to vein right now is about, it could be 6 weeks. It could be less. And I think in the next year or two or less, it will be far less, like on the order of maybe a week or two. And maybe in that same time frame, it may be a moot point because people are looking at what's called allogeneic engineered cell therapies, which is anyone named Bob here? I always use the name Bob. No. Bob comes in to get a CAR T cell, and we make that CAR T cell for Bob. It doesn't work for Susan. But right now, that's called autologous. Right now, we're evaluating allogeneic T cells in trial, which means Bob, who's a healthy guy, can donate his blood. We can make CAR T cells from Bob, and we can make treatments for dozens or more people. And that will then shrink the vein-to-vein time to 0. The vein-to-vein time is 0 for bispecific T-cell engagers. It's a drug. It's made in a vat, and you can infuse that anytime a patient is eligible and enrolled onto the trial. You don't need to wait for that vein-to-vein time. The cost is a consideration. The insurance is a consideration. And the durability of response is a consideration. I showed the one graph in multiple myeloma, but we don't know it in prostate cancer or other diseases really as of yet. So I don't know which one's better.
Got it. Helpful. Having gone through the vein-to-vein process with Provenge, I think that took a week or two. It's not a fun process, but it is what it is. So Robbo, and I'm going to call on you if you don't mind. You've got a question in the chat, and I don't think I'm going to do it justice. So I'm going to let you expand on that a little bit.
I was curious. I noticed you talked about your glioblastoma patient, and I've been helping consult with a glioblastoma patient that had resection in mid-August, IDH1 wild type 4. Chose not to do any chemo, radiation, or immunotherapy. So we've went a more holistic approach, but with diet and targeted supplements, hydration, and whatnot. But what I've come across is being able to put together a combination of dopamine receptor 2 antagonist, a GABA inhibitor, and a H2 inhibitor. Using the right combination, we're getting regression. We're 2.5 months in, quality of life's. We've resolved the edema. And it's from what I see, it's the effects, the influence it has on the P13K AKT pathway and VEGF and transforming growth factor beta 1. And we built up our immune system naturally, and it's allowing it to, by keeping the fibroblasts from differentiating and inhibiting angiogenesis, we're allowing the immune system to naturally resolve the cancer. I wasn't sure, since most of these antiemetics and whatnot are typically prescribed for cancer patients during their treatments. I was wondering if anyone's ever thought about looking more into those and how calculating the correct combination and dosing schedule and dosing amount would make every other treatment more effective.
One of my best friends studies GABA signaling in brain tumors, and I have no experience with these types of antiemetics, but I do appreciate the combination strategy. I think if you tailor it properly and understand the biology of the patient, these things can work really well.
It worked for my stage 4 head and neck squamous cell. 2 weeks into chemoradiotherapy, my tumor was gone, and I stopped treatment a week later.
Wow!
And I've had success with liver, non-small cell lung cancer. Got a 68% regression and about halfway through treatment.
Wow, I would love to learn more about that actually, because the Brian brought this up earlier. Can you combine different targets? I think that is an
Mhm.
approach, and we're all evaluating
Absolutely.
that approach. But I actually
Mhm.
think that's not the slam dunk approach. The slam dunk approach is to rewire the body and the tumor to accept these types of therapies better. And so you're bringing up one example of this, which is awesome, and I love hearing about it.
Yeah. We're rewiring it basically we're rebooting the immune system back to its natural. It's hard to get the patients
Yeah.
to modify their diet, and we're doing targeted supplements specifically for the mutation of that cancer. It takes a lot of work on the patient's side to stick
Of
to
course.
that. So the direction you're heading, yes, forcing it to reprogram is going to probably be beneficial for a large set for the people that are willing to put the front end effort in on that side. It's always going to be patient dependent from what I see.
It's always going to be patient dependent, which is tough. It's challenging.
Absolutely.
But I also think, which there's a question later on, which is something I ask myself all the time, which are like, what are the roadblocks? And I think one of the biggest roadblocks is we can we can think up. We're scientists. Like I
Mhm.
think of things every day. I go to sleep and I'm like, oh, this is such a good idea. And sometimes I wake up and I'm like, that was the worst idea. But sometimes I wake up and I'm like, oh my God, I gotta test that.
Mhm.
So there's a time implementation bandwidth challenge.
Sure.
And the thing that you're describing is awesome, but the iterations of that are crazy. Okay.
I agree.
And,
And it's
but,
actually patient specific.
but the
It's going
thing
to
is,
change for every single patient.
yes, agreed. But I don't think it has to. And I think if we
Okay.
had better laboratory models
Okay.
and could be better at predicting these things, we could implement that. I mean, one of the best questions was the earlier question, which is like, how do you predict a patient to respond or not
Hmm.
respond?
Sure.
That would be the best because not
Absolutely.
one size doesn't fit all. So we
Hmm.
know that the trial that I've spent my blood, sweat, and tears on is not going to be for every patient. But if I
Hmm.
could understand that it works for these 5 patients and not for the other 45 that I could treat, that's awesome because then the other
Hmm.
45 have an opportunity to go elsewhere to a different trial that might be better for them. Uh,
Sure.
and I think that's where our biggest roadblock is. We have tons of data emerging, and a
Hmm.
ways to analyze that data as quickly and as meaningfully as possible is the next step.
Sure. Well, thank you. Appreciate the
Yeah,
questions.
that's awesome.
Thanks.
Congratulations to you. That's
Yeah, Rob's an amazing patient, as you can see. We actually did a webinar on him. If you're interested, I could send it to you.
I would love that, and Rob, I may hound you more than you would probably hound me.
I would like that. I'm actually meeting with Chris Gregg from University of Utah School of Medicine tomorrow. He's a human genetics and neurobiology gentleman. I just got back from the RGCC conference in Denver, speaking with integrative oncologists and oncologists. So yeah, I would love.
Yeah,
I'll send you my email and
yeah.
let's.
Please do. Yeah.
Awesome.
Awesome. Thanks, Rob. So Elaine Watkins has a question about rare solid tumors, such as thymoma,
Yeah.
and success, etc.
One of the issues that we all deal with is funding as well as incidence. And so some of the rare cancers don't get a lot of attention, unfortunately, because there's limited funding for that. And one of the examples is that, so I'll give you a little story. 10 years ago, I got married to my wife, who's still my wife. And 4 months before we got married, her father, my father-in-law, my father-in-law was diagnosed with pancreatic cancer, and so we were dealing with a lot of shit at our wedding. Decided to get pregnant to make him a grandchild. We were successful at that. Donna, my wife, was 1 month pregnant or 1.5 months pregnant at our wedding. Her dad unfortunately died 8 months later after diagnosis, which was 2 months shy of meeting his grandchild. So I went into the lab and I'm like, I'm going to develop pancreatic cancer therapies, and there was no funding for pancreatic cancer. So I redirected, don't tell Prostate Cancer Foundation, I redirected some of the opportunity we got from Prostate Cancer Foundation to develop that PSCA CAR T cell, with the knowledge that it was going to be effective in prostate cancer. And we just published that phase 1 trial in Nature Medicine, and we're on to the next trial, and we're really working on that for prostate cancer. But in the back of my head, I was like, PSCA is even higher expressed in pancreatic cancer. So here at USC, we're moving in that direction to develop it for pancreatic cancer. And I can realize that now, because fast forward 10 years from 2013, there's way more funding for pancreatic cancer now, even though the incidence of pancreatic cancer is about 50 or 60,000 a year versus prostate cancer, which is in the hundreds of thousands. There's just more funding for it. For thymoma, it's really rare. There's not a lot of funding, and I don't know much about it, admittedly, and would have to look at it. But yes, I mean, technically, we could develop these types of immunotherapies for any disease if one has the indication to do so. With respect to autoimmune disease, it's like all the rage in the last year, where we're applying CAR T cells to autoimmune diseases and seeing striking, durable responses in things like systemic sclerosis and lupus and other autoimmune diseases. So I think that's the next frontier as well, in treating autoimmune, which is unbelievable.
Yeah, agree. Lots of applications. And so appreciate your brain wrapped around it and having many ideas as you go to sleep and wake up in the morning. Roger Royce is a pancreatic cancer patient. Roger, you've got a question. You want to jump in here?
Okay, thanks. So my brother had Burkitt lymphoma, and he died last year, and he never had the opportunity for CAR T, and I always thought that might have made a big difference. And I was wondering if you know what the success rate is for that. But more importantly, it seems like this is not offered that widely, because he wasn't even available to him at the hospital, the small city hospital he was involved in. So I'm wondering, that's the second part of this, is when does this become, it sounds very promising, when does it become a little more mainstream?
Yeah, so the one thing is, appreciating the complexities to this type of therapy, and the idea that right now, probably at the small community hospital, it's more challenging to receive this type of therapy than at a cancer center. So it gets to point of care, and those things are changing, and especially for certain diseases where the therapy, without CAR T cells for that therapy, patients are dying. Like for certain lymphomas and leukemias, they should be receiving this therapy. And now some indications are saying they should be receiving this therapy before they ever see a chemotherapy. Like, they should be on this therapy as frontline because it's so effective. So I think over time it will be more readily available. And as I mentioned before, maybe with allogeneic cell therapies, where healthy donor A can give to patient B through Z, or shrinking the time of manufacturing, and opening sort of fully closed manufacturing systems that are like in a box, you can deliver to the community hospital and they can do it there without much manual intervention. Yeah.
Thank you.
When was he treated?
He was diagnosed in February of year, and he was treated in Spokane, Washington. He went into a complete they told him he was in complete remission in August. In October, he died. And I always wondered if he had done what you said, if he had gotten CAR T right at the front from Fred Hutch or someplace.
Yeah.
I can do it. It might have made a difference. And it's kind of shocking, just cancer care generally, just how disparate the treatment is. Because we do this every week. We have these sessions and we hear about these great new therapies.
Yeah.
And it's like, unless you're tuning in every week and hearing this, you might not know anything about it. Nobody told him about it. I didn't even know about it until it was too late.
It's been one of my biggest pet peeves and gripes around our healthcare system, is that hospital A, that's on the same street as hospital B, has a very different definition of standard of care. And we should be all in the same boat, or at least sharing all of that information so that we can funnel and come to a consensus on what those therapies should be at which stage and which patient and so on and so forth.
Yeah.
So related to that, I had a thought about, who is the ideal patient, not only from at a transcriptomic or a DNA level, but from a treatment perspective. So, are you looking at patients that are heavily pretreated or those that are less pretreated? I'm sure it varies by setting, but just curious to get your thoughts on that. I'm kind of hearing that you'd rather it be earlier in the process, which I think in the journey, which makes sense, but
Yeah,
maybe if you can
I mean, I
elaborate.
can make blanket statements, which some of them may not be correct or they're evolving, but I think the healthier the patient, obviously, the better to receive this type of therapy. In terms of tumor burden, which is how much disease a patient has, it could go one way or another, and I think it's context and disease dependent. But in certain diseases, it's logical that the lower the disease burden, the better chance of a therapy response is. In certain tissues where the metastatic disease may predict whether there's a response or not. So for instance, if you have liver metastatic disease, your likelihood to respond to certain types of immunotherapy is less than if you don't have liver metastatic disease, and that's just unfortunately what we've seen. There are tons of things that we could apply, and I'm not sure they are ground truth.
Yep. Okay, great. Rick Davis, you've got a couple questions. Your last one is about PSCA expressed in pancreatic adenocarcinoma cells. You want to jump in and ask? I think you had a couple questions. Is there anything you want to elaborate on?
Thanks. Hi, Saul. I'm blown away only because I actually have understood most of what you've presented, which is amazing. Because I'm one of the less technically astute that's on this call.
It's because you're British, Rick.
What's that?
Are you British?
50 years ago I was.
Yeah.
I'm an
Yeah,
expert.
it's because you're British, because I'm British too. That's why.
Oh, really? But you sound less British than I do.
Well, I was born and raised for 2.5, 3 years in London, but
In London. Yeah. I've seen you before presenting, but I thought it was Cancer Lab, but it obviously wasn't, because now I remember you saying that. I heard that in the last, maybe
yeah.
it was a PCF thing. Anyway, a couple of questions I've answered for myself in the interim. But two things. One is, it's very interesting to me that PSCA is expressed on pancreatic cells. I'm wondering if we have any idea why, and it seems like there's a potential. And the other question I was going to ask you was, is your lab doing any work on trying to make cold tumors hot?
Oh my God, it's all my lab works on. So PSCA was a misnomer when it was discovered as a protein. They called it prostate stem cell antigen because it was literally found in the prostate epithelial cells that the prostate cell, the normal prostate cells that they thought were stem-like in nature. So they just called it prostate stem cell antigen. But then a bunch of scientists come around and are like, oh, that's a cool thing. Let me see where it's expressed. And they identified that it's expressed in some other tissues, including pancreatic cancer. They just don't change the name. So it's called prostate stem cell antigen, but it's also highly expressed in other tissues, including bladder cancer, which we're also very interested in treating. As USC has, like, I didn't know this prior to coming here, but they have one of the highest rated, if not the highest rated, urologic groups around bladder cancer and treatment. And TCE is sorry for confusing, but they're the same thing. It's the reason that is the way that it is because bispecific T cell engager stands for BiTE, or BiTE stands for bispecific T cell engager, and BiTE was trademarked, I think, by Amgen. So people used it and then got into trouble. So now we just call them TCE, T cell engagers.
How about commenting on making cold cells,
Oh,
cold
yes.
tumors hot?
Yes, it is all that I think about because so we've done a lot of analysis on the trials that we've done out of my lab. So again, we're actively in clinical trial in prostate cancer, breast to brain metastases, and ovarian cancer. All of them are deemed immunologically cold. And so my lab really does work, and it gets to what Rob was talking about earlier, which is a bunch of different therapies that by themselves may be ineffective, but in combination or in advance of an immunotherapy could prime the tumor to better receive and allow survival of those cells, survival of those adoptively transferred T cells. So that's all my lab works on. And specifically now, well, we do it across a couple of cancers, but we've built awesome models, which I'll say it, and I haven't presented it because we haven't matured it enough, but around pancreatic cancer, because the vast majority of pancreatic cancers are immunologically cold, and we've built models where there are some that are cold, some that are warm, and we're literally breaking that down into the cell and the gene level to try and understand that, with the idea, Rick, that we'll go back in and make those tumors immunologically warm and can apply cellular therapy and have the responses that people are seeing in melanoma and other cancer types. That's the idea.
Great. Thanks, Rick. Thanks, Saul. So we've only got a couple minutes here. And before I ask one final question, which is, I think, required of any conversation happening today, I wanted to open it up to anyone else who might have a question. Okay. So, Saul, given what's going on with AI, how is AI getting integrated into your work? Are you seeing it accelerate the R&D efforts? Yeah, just comment on
that. Probably guilty. I haven't gotten into it as much as I should, but we are implementing several things around machine learning and to try and better analyze data in a quicker fashion. That's how we're probably implementing it the most. I think the coolest thing, which Brian, I think we learned about in Prostate Cancer Foundation, was this AI group that could take a prostate tumor that was biopsied or resected in a prostatectomy, and using AI could predict the stage and therapy angles better than a pathologist could. I forgot what the company was called, but I think that's where we will go. And there's a bunch of AI labs at USC, and we collaborate outside of USC. I think what would be really cool is getting to the question we're all asking is, how the hell do you predict that a patient will respond? And I think AI will be the best implemented in that set.
Yeah.
Taking all the data you can get from a patient, and hopefully in the most non-invasive manner, and try and predict what therapies are will be most effective.
Great. We're at the top of the hour. Rob's got his hand raised. Do you have another minute, or do you gotta jump?
I have to leave. I have another minute.
Okay. All right, Rob.
So I'm using AI right now to, when I get the mutation and the variants, I work backwards from that to identify what multivitamin or what vitamin, mineral, or amino acid deficiency or imbalance may drive that mutation. Then I build from that a targeted diet and supplements that will help rectify any DNA damage that's being done during nucleotide synthesis. And then build, and I use AI extensively to follow through, looking for pharmacological reactions between the antiemetics and the GABA. It's remarkable when you ask it the right questions and fine tune this, the information, the valuable information that supplies, at least from my perspective.
Absolutely.
You guys should probably meet offline.
I
Rob's-
already got an email draft to you, Rob.
Okay. Awesome. I'm going to shut down the recording here.